Well, hello everybody, and welcome to the December edition of the European Urology Podcast. This is Declan Murphy speaking to you here from the GUcast studio in Melbourne. Unfortunately, this month I'm not joined by my co-host Joyce Baard from Amsterdam. Joyce, unfortunately, as is the way when we're trying to set up a recording like this, has had to pull out at short notice due to some issues going on back in Amsterdam. Just to give you some idea, when we try and put these podcasts together, we try and pick a 1 hour segment once a month where we try and coordinate me in Melbourne, Joyce in Amsterdam. Last month we had Nikita in India and guests in Vancouver, Baltimore, the UK and Italy. So as you can imagine, the scheduling is a bit of a challenge, and somebody, usually me, is having to get up at some ungodly hour to meet the time zone challenges. But unfortunately, yes, you've got me on my own this month as I bring you the highlights of the December edition of European Urology. And coming up this edition, we've got some fantastic stuff. We have picked two highlight papers as usual, one of which focuses on bladder cancer, the role of atezolizumab in high-risk non-muscle invasive bladder cancer. That's the SWOG 1605 study, which is in this month's European Urology. And second, we have a very interesting paper led by some of our radiation oncology colleagues looking at genomic and imaging features of oligo-recurrent prostate cancer. That's all coming up later. As well, our usual segment with Nikita, where we ask her to highlight some other papers that caught her eye in the paper, will be presented this month by Bernard Jansen. You might recall Nikita has gone on maternity leave for a few months. We put out a shout to see could we get some enthusiastic trainees out there to cover her segment for a few months. And I'm delighted to say that Bernard Jansen from Amsterdam will join us this month. And we have different other candidates lined up for coming months. If you're interested in covering this slot, please do get in touch. You can email us at platinum@europeanurology.com and express your interest. So first of all, I'm going to go and cross over and talk to Peter Black and Carmen Muir, who are going to talk through the SWOG 1605 study. So for the first paper that we've selected for this month's European Urology Podcast highlights, I'm really pleased to welcome two fantastic bladder cancer experts. Yes, we don't do enough bladder cancer in general, so I'm really pleased that we've selected a bladder cancer paper as one of our highlights. This is the phase 2 trial of atezolizumab in BCG unresponsive high-risk non-muscle invasive bladder cancer at the SWOG S1605 study published in this month's European Urology. And it's a great pleasure to welcome lead author on this trial, Professor Peter Black. Peter is a urologist and professor in the Department of Urologic Sciences at the University of British Columbia in Vancouver. Peter, thank you very much for joining us on the European Urology Podcast.
Yeah, my pleasure, Declan. Thanks so much for inviting me and focusing on this trial.
Yeah, and to discuss your paper, I am really pleased to welcome bladder cancer expert, fellow urologist, Dr. Carmen Muir. Carmen is a urologist at La Ribera University Hospital in Valencia in Spain, and she's also the chief editor of the EAU's EuroOnc educational platform, which is a really good resource, and a big bladder cancer expert. Carmen, thanks very much for joining us to discuss Peter's paper.
Thanks, Declan, for the invite.
Terrific. So we've got about 10 minutes or so to run through this. So obviously we can't get into the entire detail of this very interesting paper. But what we'd like Peter to do, if he wouldn't mind, just kick off, give us a really brief top-line summary. Of course, all the details in the main paper. You can look in the show notes to get a link directly to that paper. And then we'll hand over to Carmen to ask a few questions. Over to you, Peter.
Yeah, thanks, Declan. So this was, I would say, one of the typical single-arm phase 2 trials in this disease state. So it was patients with BCG unresponsive carcinoma in situ, and they were treated with atezolizumab for 12 months, so intravenous atezolizumab. The primary outcome was complete response at 6 months with a mandatory biopsy, and 27% of patients had a complete response. And then we looked also at the duration of response, meaning 12 months later, so 18 months in total. And at that point, about 50% of those who had responded were still responders. The downside was toxicity. So about 13.5% had a grade 3 or greater adverse event. And I think that those are the highlights.
Yeah. Thank you, Peter, for the summary. So what happened was that the first approval that we had was the Pembro one, right, in 2020, more or less, for the BCG unresponsive. And since then, we had other treatments coming out, but the only one that is equivalent to the one you presented is the Atezo trial. And we see in that trial that you also had the second cohort with the papillary tumors, right?
Right.
What do you think that makes it a little different from the CIS cohort? Is there a role for TURBT to make a difference in this setting?
Yeah, I think so. First of all, I'd say that this trial is very similar to the Keynote 57 trial, and the results actually are very similar as well, both the efficacy and the toxicity. And Keynote also had a papillary group. I think the TURBT is a big part of management, obviously, of the Ta/T1 tumors. You're eradicating all disease, and then the treatment, in this case, atezolizumab, is really like an adjuvant. And a lot of patients will remain disease-free regardless of what you give them because you've resected adequately. So the results look better in papillary versus CIS, but that's, I think, the impact of the TUR. And the only way we'll know what the drug is actually doing is by comparing to patients who get either a different drug or nothing. And that's why these drugs are not approvable in the Ta/T1 subgroup based on a single arm trial, because the FDA also sees it that way. You need that comparison to truly determine efficacy.
So speaking about that, we recently got the results of another trial in the same setting, the TOR2, that was presented at ESMO. And in that trial, is a little different definition, BCG unresponsive and BCG experience are available. And there are two arms in that trial as well. Can you get any conclusions out of those differences? We show actually that we can do trials with two arms in that setting, probably out of TOR2.
Yeah, I think, so the BCG experienced, we wrote a paper in European Urology and called it BCG exposed, which I think has become the more standard terminology. But it's patients who've had BCG before, but not enough to make them BCG unresponsive. And so it's especially patients who've had only induction, no maintenance. And so it's an important patient subset, but they have very clearly different prognosis and need to be managed. It needs to be handled differently in a trial. So they need to be separated, and it needs to be a comparative trial, because the standard of care for patients with BCG exposed disease is to get more BCG. They haven't exhausted that. So you really need a comparator trial. And so I don't think that TOR is necessarily definitive, but certainly very interesting to look at FGFR targeting in that setting.
So if we look a little bit further in terms of how we look into the future, how do you envision the field to evolve in this BCG unresponsive area of the disease? Do you look into two drug trials? Do we look into comparing between drugs, into sequentialing? Do we look into going into an intravesical treatments only, chemoresection like TAR-200? There are so many options out there that sometimes it's cumbersome, right? But
so
do you think?
The short answer is all of the above. So I think there are a lot more options out there than just immunotherapy, and some of them look really good. And nadofaragene is FDA approved as well. That's the adenovirus that expresses interferon. So we'll see that in the US market relatively soon. But I think that the results of nadofaragene and pembrolizumab and atezolizumab, they're all relatively modest, so they're not really home runs. And so we're really looking for that next level efficacy. And so I think combinations will be super important. And I think comparative trials will be important. So I think we've gone beyond the single arm trials, and we now need to compare. And we are seeing some trials come online that are comparing different treatments, and especially combinations against each other or combinations against single arm. So we'll see that for sure, specifically in BCG unresponsive.
Mm-hmm.
Peter, can I jump in and ask a question about the costs of IO in this very early disease setting? For most countries around the world, Australia certainly included, we'd need to be, showing something like OS, like considerable OS, to get really expensive IO strategies, especially combination, over the line. Have you any thoughts on that? Will we be able to reach that with these early disease settings rather than, the metastatic disease setting, it's much easier. But in this disease setting, it'll be a real challenge to get to that type of endpoint that might satisfy reimbursement bodies around the world.
Yeah, so I think in non-muscle invasive disease, we don't even talk about overall survival because it's so far off. And I think, in the BCG unresponsive setting, even the sort of the latest stage of non-muscle invasive disease, you don't see big differences even a few years out. So I'm not sure if we'll ever get overall survival, but if we can have a big impact on cystectomy rates, for example, which is a very clear, well, nothing's clear about cystectomy because so much of it is subjective, the decision to do it or not, but it's very clear that we want to avoid that. So I think we will have to be satisfied with other endpoints. Cost is very interesting because we all think of immunotherapy as having the prohibitive cost, but I think we're going to find out that any one of these novel drugs will be just as expensive as immunotherapy because it's as expensive as the companies make it. And nadofaragene, for example, is supposed to have a fairly significant price tag that'll be no better, I think, than immunotherapy. And it's given once every 3 months intravesically. So it's actually very easy to administer, but difficult to make.
Yeah, and Carmen, again, we're veering off the paper a bit, but while we've got two great bladder cancer experts on the line, why not? I think urologists are definitely interested in the really big advances in intravesical therapy with these pretzels and so on coming along. Are you excited about that? Do you think that because it really gets urologists involved when we're still, doing cystoscopies and taking these pretzels in and out and so on. And it's a real multidisciplinary thing because we'll work very closely with our GU medical oncologists in choosing what's going to go into these pretzels. But are you excited by pretzels?
Definitely, I have to say I used it myself in one of the initial trials, and it was very easy to handle it from the urology perspective. It's a flexi-cystoscopy, nothing major. So very attractive for urologists. And I think that the results from TAR 210 that were in ESMO about the chemo resection, like patients that were intermediate risk and they already knew that they had low-grade disease. And they got like 87%, something like that, complete responses only with the device in the bladder, which is kind of a lot, I would say, from a urology perspective.
Totally agree.
I think, sorry, Carmen, to interrupt. I think we're going to see a total paradigm shift where we actually do primary ablation and don't insist on TURing everything. And I could just imagine your patient where you suspect that it's a low-grade TA tumor, for example, if you remove cost from it, because of course putting in the TAR 210, so the pretzel with the FGFR inhibitor is not going to be cheap. But in principle, you can imagine just deploying one of those when you see a tumor at the time of diagnosis, and then just do a cysto 6 weeks, 8 weeks later. If it's gone, you're done. If it's not, you take them for TUR, and it could totally change how we treat patients, especially. Also, if we were better at detecting FGFR alterations in urine, you match the cysto with a urine test, you treat with a device, and you remove TUR from the paradigm.
I love it. What a disruptive vision for the future. Well, thanks very much to Peter and to Carmen for joining us for that discussion. This paper is in December edition of European Urology Podcast, and the links are in the show notes. Thanks very much to both of you. So for our second paper this month, we're switching back into prostate cancer. This is a really interesting paper for any of you interested in novel imaging. It's the clinical and genomic differences between advanced molecular imaging detected and conventional imaging detected oligometastatic prostate cancer in the metachronous setting, in the recurrent setting. So this is a paper led by Phil Sutera, who's a radiation oncology resident at Johns Hopkins over in the US. And it's a great privilege to welcome Phil and congratulate him on this paper. Phil, thank you for joining us on the European Urology Podcast.
Thank you so much for having me. I'm looking forward to talking about the paper.
Yes, and to discuss your paper, we're joined by one of our consulting editors at European Urology, Giorgio Gandaglia, who's a urologist at San Raffaele University Hospital in Milano. Giorgio, thank you for joining us.
Thank you for the invitation. It's a real honor to be here.
Great. So this is a short slot where we want to really highlight this paper and get some robust discussion going. So we're not going to dive into it in huge detail. We're linking to the paper down in the show notes, so please do go and have a look. But we will ask Phil just to briefly summarize this study and the top line messages before we ask Giorgio to lead the discussion. Over to you, Phil.
Sure, thanks. So with the rapid increase in use of molecular imaging, I think across prostate cancer, a lot of people have been wondering how this stage migration is going to affect management and outcomes, particularly given all of the data that we have is in the conventional era. And so our group is specifically interested in metastatic prostate cancer, and even more specifically, limited metastatic prostate cancer, in which metastasis-directed therapy may have benefit. You can imagine that if you're thinking about defining the volume of metastatic disease, that the sensitivity of the imaging that you use is going to dramatically affect what you come up with. And so we were very curious to see if there was any differences between patients who had molecular-based staging for oligometastatic disease, think choline PET or PSMA PET, versus those that had disease present on conventional imaging. And so we looked at our retrospective cohort, multi-institutional cohort of men with oligometastatic prostate cancer who underwent next generation sequencing, and then classified them according to what staging imaging they had. We included patients who are metachronous oligometastatic disease, so patients initially with a localized prostate cancer who received definitive therapy with subsequent metastatic recurrence, again, either on molecular imaging or conventional. And patients with molecular imaging only were defined as those that had disease that was only identified on the molecular image that did not have a conventional correlate. And those in the conventional arm may have had molecular imaging detected disease as well, but the defining feature of them was that the disease was picked up on the conventional scan. So we ended up with about 300 patients, just under 300 patients. And when we looked at the clinical characteristics between the two of them, we could see that those that had conventionally detected disease had, as you might expect, a higher PSA at time of metastasis, indicating the being found later on in their course, as you may expect, but also had higher Gleason score. What was particularly interesting when we looked at the tumor genomics is that patients with conventionally detected disease had higher likelihood of having a P53 mutation, which has been shown in metastatic disease to be associated with worse prognosis. And they were less likely to have an SPOT mutation, which is a more favorable mutation in metastatic prostate cancer, generally indicating that the conventionally detected metastatic disease, potentially, at least from a genomic standpoint, had more aggressive disease. I think what was then kind of compounding with that, interestingly, when we looked at their outcomes, we looked at overall survival, both from time of metastasis, but also from time of initial localized prostate cancer. And from time of metastasis, as you may expect, survival was better in the group that had molecular-only detected disease, though you could easily say, well, that could be explained by a lead time bias with just earlier detection. But what was particularly interesting was when we looked at time from initial localized prostate cancer, survival was similarly better in the molecular-only group, indicating that it wasn't merely a lead time bias difference that we were seeing, and potentially actually that the molecular disease was less aggressive, which was concordant with the genomic data as well. And so I think, taking these findings together, following, this work certainly needs to be replicated and validated. But if it were to be the case, I think it gives us a lens to which to view several upcoming clinical trials in this space that are, using molecular imaging and kind of putting it, the important piece that we need to recognize whether or not there's conventional correlate disease as well. And, we can talk about through discussion, if necessary, that some of the hypotheses of why this difference might be there, but certainly give some interesting first insights into these differences.
Really interesting, because when I started reading this paper, I thought, oh, come on, this is just going to just tell us that there's a lead time bias. Oligometastases that we pick up much earlier on on molecular imaging are going to have a better outcome. But it's very interesting, the idea that there is a biological difference between those patients. Now, retrospective study, as you say, it needs prospective validation. But yeah, Georgia, over to you. What caught your eye on this paper?
So it's a great study, and congratulations. We are entering in a PSMA era where virtually all our patients with a biochemical recurrence receive a PSMA PET. So which are the practical implications? Are you performing a double contrast PSMA PET CT? And is this something that is basically allowing you to assess also the presence of conventional metastases or conventional imaging detected metastases at the time of PSMA PET to identify those patients who are the ones with a worse prognosis?
Yeah, I think it's a great question in terms of what do we do moving forward from this. You know, a lot of the patients in our study had both conventional CT bone scan as well as PET scan, and those that didn't have both a CT and bone scan, we based it off of the CT portion of the PET. And so whether the CT portion of the PET scan is sufficient to tell us, you know, there's conventionally detected disease, or whether we need formal conventional imaging, I think that's to be determined. But it's certainly something that we need to be thinking about and considering as we move forward.
Thank you. And when I read your paper, I see, and it's very interesting, and maybe you can give us some suggestions and some practical advice on how to use next generation sequencing. You basically assessed the primary tumor and, when possible, the metastases. So what are you currently doing in your clinical practice when you have a patient like this with a biochemical recurrence and a positive imaging at the time of BCR?
So our preference is to go back to the primary tissue. Obviously, this is metachronous, so whether it was a biopsy or a radical prostatectomy, that is typically what we've been getting in the setting where the NGS failed on the primary tissue, and that's when we went for the metastatic site.
So you consider also bone biopsy, for example, when the primary tumor is not sufficient to get enough samples or enough tissue for the analysis?
Occasionally. I don't know if we're routinely biopsying a bone lesion solely for the purpose of next generation sequencing in this setting yet. In the hormone sensitive space, DNA mutations aren't driving treatment to the same extent that they are in castration resistant disease. Though, you know, as we continue to move forward and learn more and more about how these mutations are affecting prognosis and may have differential response to treatment, I think it's going to be something we're certainly going to be needing to do in the future. But I think right now, you know, it's not always 100% mandatory that we're getting NGS on these patients with oligometastatic disease, but it's certainly helpful if we can get it.
And going back to the practical implications of your study, what I found really interesting is that basically you included only patients with positive imaging. So basically we are missing a group of patients with a negative imaging. And this is key when we consider that often urologists around the world are tempted by the idea of not to treat patients with a negative PSMA. So basically they wait for a positive imaging before starting metastasis-directed therapies. So it will be highly interesting for me to know whether the results you observed in your study can be replicated also in patients with a negative PSMA PET, for example, and compared to those with a negative conventional imaging, but maybe a positive PSMA PET. What do you think about it? Is this something you plan to do in the future?
Sure. I think it is something that we haven't thought of necessarily, but I certainly think is important in terms of not only are we missing the, you know, molecular biochemically recurrent, but we're also missing some of the, you know, higher volume disease in terms of molecular polymetastatic and conventional polymetastatic. And so there's certainly the spectrum. I would be interested to see how, you know, molecular imaging negative biochemical recurrence behaves and what the tumor genomics there are and how those outcomes behave. You know, we often are still, in the radiation oncology world, we're treating these patients with salvage radiation often to the prostate if they had a radical prostatectomy. And so, our clinical practice here, at least, is to not hold off until there's metastatic disease, but certainly something interesting to think about in the future.
Phil, can I ask you a question about the imaging? Because this is a retrospective study, of course, but it wasn't just PSMA PET. It harks back to an era in the US where much less interesting tracers like choline and fluciclovine were being used, and that's just the nature of this study. But those tracers really underperform when compared with PSMA PET CT. Did you notice any differences between PSMA detected novel imaging versus other novel imaging?
Yeah, so we had a supplemental in the paper, so I'd have to look specifically at the numbers, but I believe the PSA at detection of metastasis was lower in the PSMA detected patients versus those with choline or fluciclovine. We did not end up looking at clinical outcomes. We may have looked at genomic differences between them, but I don't think there was anything striking.
Very good. Giorgio, any last questions for Phil? And I've really enjoyed your discussion, I have to say.
Just a very last question regarding your results. Basically, what we observed, and I was surprised about it, is that the time from treatment to oligometastatic disease detection was similar between patients managed with conventional imaging and those with a positive PSMA or, let's say, molecular imaging. So how do you explain this? Is this something you expected? Is this related to the use of different tracers, for example?
Yeah, so it certainly wasn't something I expected. I think when we went into this project, I was expecting the time to metastasis would be much faster in the molecular detected patients. The way that I am rationalizing it is that patients with more aggressive disease, so those with P53 mutations, those with higher Gleason score, by the time you're getting your follow-up PET scan, the disease is growing faster and so possibly then detectable on the conventional portion. Whereas more indolent, slower growing disease, even though you're checking routinely, at some point you're more likely to catch it before it's big enough to be caught on a conventional scan. And so that's kind of how I was thinking. And so the time to development of metastases was similar, but that was just because likely in the conventional cohort, it was more aggressive disease and growing faster.
That is fantastic. Georgia, I'm going to ask you a question to finish. We had Pete Ost on our GUcast podcast last week talking about lymph node only metastases. He was joined by other radiation oncologists, Shankar Siva, and by Michael Hoffman, PSMA imaging expert, of course, from here in Melbourne. And a comment that Pete made was, well, look, if we're going to be going after low volume disease, we must be using novel imaging. Is that your thought on how we should identify this group of patients who may benefit from metastasis-directed therapy? There's no point in waiting for conventional imaging to be positive. We must do novel imaging. What are your thoughts from Milano?
Completely agree with you. And we recently completed our analysis for the upcoming meetings. And what we observed is that even when we have a positive molecular imaging, a positive PSMA PET, we are still missing the disease. So the underestimation of the real disease burden is there also in the molecular imaging era. And we should be aware of it when we treat our patients.
Very good. But I think a final message from Phil's paper is don't forget the biology. Have a look at what's driving these actors as well. Well, look, congratulations, Phil, to yourself and your colleagues. Pete Ost is one of the senior authors on that paper, of course. And we congratulate you on this work. And Giorgio, thank you very much for joining us. So for our final segment on the podcast, I'm really pleased to welcome a new contributor on the European Urology Podcast, Bernard Jansen. Dr. Bernard Jansen is a senior urology trainee at Amsterdam University Hospitals. He's filling the boots of Nikita Batt, who regular listeners and viewers will know is off on maternity leave for the next few months. So while Nikita's off, we're welcoming probably a different contributor every month just to rotate around. So if you're out there listening to this and you're a urology trainee, we'd love to hear from you if you want to get involved in this segment. So Bernard, thank you very much for joining us.
Thanks so much for having me, Declan. It's an honor.
Great. Well, look, we love having new faces on the podcast. So tell us a little bit about yourself.
So I'm an fifth year resident now in urology. Highly enjoy my field and my field to be. So I currently work in the Amsterdam University clinic, but having done some rotations in the peripheral hospitals around Amsterdam as well. I have a PhD in prostate cancer, which was done pretty much in the same studio setting here because it was also during COVID times. So, yeah.
Excellent. Well, congratulations. And we love having trainees on because it sometimes gives old people like me a chance to find out what you young people are up to. So are you on Twitter, for example?
No, actually, I'm not on Twitter. And especially not since it was hijacked and called X these days.
I know.
No.
It's shocking, So for you, those of you out there who are old like me, who grew up in the Twitter era, and we loved it. It was a great way of connecting with people around the world, making new friends. It's definitely in a death spiral. So when we have young urology trainees like Bernard dialing in from a European country, no, I'm not on Twitter. We're not even interested. I know that the death of Twitter is in sight because no young people are joining it anymore. So I'm afraid it's just increasingly a shrinking pool of people like us who are nostalgic about the great days of Twitter over the past 10 years. And what about podcasts? Do you listen to podcasts, or do you and your generation enjoy podcasts?
Yeah, very much actually. I think that's actually, I think, somewhat interesting why that's really popular, I think, among our generation. It's so nice to combine it with other activities, of course, just driving a car, going for a run, these kind of things. So I definitely enjoy podcasts, yeah.
Yeah, totally agree with you. Okay, well, look, so your segment is about highlighting some of the other content in this month's edition of European Urology. So we've had 2 great papers on already for some in-depth discussion, but you're going to give us 3 other papers that caught your eye in the journal this month.
That's correct. And well, thanks again for inviting me to be a stand-in for Dr Baard. I really do feel I have some big shoes to fill because I heard she is actually having 2 babies, but still she managed to publish in this edition of European Urology. So that's really really impressive, and I would surely recommend also to read that paper that Dr Baard was writing. She wrote it on social media interventions in urology, and she comes up with some, I think, very interesting, real life, convincing data that engaging in social media can actually improve healthier behavior of our patients and even the outcome of our patients. So that's very convincing, I think. And Nikita is stressing that if we as healthcare professionals, if we are planning any new social media activities, that we really need to make sure that we include patients in that in a timely manner, and even before actually doing so, to really choose the right social media strategy. And it might not be Twitter, as we just discussed.
Yeah, it's a really important message, isn't it? A simple thing like social media. And of course, increasingly, patients are in an era where they've been using social media because if it's not themselves, but their kids may have been involved, so they connect with them. But guess what? There may be a way of using social media as part of delivering better health or wellness or awareness. There's lots of opportunities. So Nikita's piece is all about that. And of course, the EAU Dissemination Committee, the Guidelines Dissemination Committee, is very interested in using social media. And Nikita is actually a member of that committee as well. So I think this is all in a familiar terrain of using social media, not just for ourselves and for connectedness, but perhaps as a way of improving the way we deliver health or we assess patients with healthcare needs. That's a good one. Bernard, what else?
Well, what further caught my eyes was this month's contribution to surgery in motion. Always an interesting section. And well, apparently already in 1906, strictured ureters were replaced with ilium segments. But now there's this team from Peking showing nicely that it can be done fully robotically now and fully intracorporally as well. I think that's very nice work, what it shows there. I really hope it will eventually also report long-term results. Because it is kind of surgery. I mean, I think doing this kind of surgery is one thing, but like really keeping an eye for the long-term risks and complications is also something I'm very interested in.
Yeah, and of course, Surgery in Motion is our flagship video paper every month. It's been one of the most popular sections in the journal for very, very many years now. So we'll put links into that in the show notes. And it's one thing to describe something, but when you've got a video of a complex technique like robotic reconstruction, it's great to see. And actually, before I forget, we will be inviting on our new Surgery in Motion editors, Nina and Ruben, to talk a bit about that section and their plans for it for the future. And you have one more, I think, Bernard.
It's true. Like a young urologist to be like me, we should always keep a close eye for the words of wisdom section, I think. And well, to me, like tibial nerve stimulation, that always remains somewhat magical. It's far away from the urological system, and well, I don't quite understand it. But our colleague Kulewicz is really enthusiastically discussing some previous results on changes of brain behavior after tibial nerve stimulation. And in that paper, the author suggested that we are close to breaking down a, quote, unsolved 21st century urologic mystery. So I really believe we have to read upon that more.
Excellent. Yeah, Words of Wisdom is a really nice section. It's very popular. So this is where authors will do a very brief summary of a paper and then usually a quite editorial style opinion on that paper. And classically, it's papers published in other journals. So it's what caught our eye elsewhere. That's great. Bernard, thank you very much for highlighting those papers. We'll put links in the show notes, and I wish you all the best with your training. We look forward to seeing you and some of that younger generation at the EAU next year. Maybe you can give me a few lessons on what platforms are of interest to the younger generation.
Well, thanks so much for contributing. It was very nice.
Thank you. So that's all we have time for on this month's European Urology podcast. I do hope that you enjoyed it. Please do reach out to us with your suggestions. We love hearing from you. Please do subscribe and do rate and review us if you have the energy. It really helps us, and we listen and watch every comment that comes our way. We'll be back in the new year with lots more highlights from the January edition of European Urology. In the meantime, we wish you all the best for a great Christmas and a happy new year. Thank you.